Welcome, and thank you for joining this week's webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing webinar series. During this webinar, participant microphones have been muted. However, we encourage you to make use of the chat box to communicate with the presenters and to ask questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. We are also pleased to share that this webinar series will be extended by 4 additional sessions, and it's now concluding on July 1st. If you would like to submit an operational topic for consideration for a future webinar, please write to us at ready@safechildren.org or use the chat box during this and future webinars. It is now my pleasure to introduce our moderator for today, Director of the Health Emergency Information and Risk Assessment Department in the World Health Organization Health Emergencies Program, Dr. Oliver Morgan.
Thank you very much, Ryan. Hello to everybody. Good morning and good afternoon and good evening. I'd like to just start by thanking Paul Spiegel and Johns Hopkins for inviting me to moderate this session. It's a very exciting session, a topic that we've been working on closely with many partners over the last few months. It's my pleasure to also introduce 3 excellent speakers for today. We have Dr. Niluka Wijekun, who is a medical epidemiologist at the World Health Organization in the Health Emergencies Program. We have Dr. Heba Hayek from UNHCR. Dr. Hayek has been working with UNHCR in the public health unit in Jordan for nearly 7 years. And we also have Naomi Garuya, who from Kenya. Naomi has been working with community health services in humanitarian organizations for at least 20 years. So my thanks and welcome to the 3 speakers that we have. We'll have presentations from each of the speakers and then a question and answer session. And we'll be focusing this session today on surveillance in humanitarian settings, surveillance for COVID-19. It's a particularly challenging area. Surveillance for COVID-19 is a challenge in any setting, but it's an especially big challenge for populations who live in vulnerable settings and in humanitarian settings. Now, there are a wide range of different challenges, and we'll hear from our speakers about those challenges. But I think the overriding principle, an important point to note from a public health perspective, is that disease control requires all populations to be served. And this is an overriding challenge in all humanitarian settings and also for many non-humanitarian settings as well. The control of infectious diseases, especially for COVID-19, does require us to pay just as much attention to vulnerable populations, or maybe even more attention to vulnerable populations, which in its own right can be challenging when those populations are either marginalized or underserved for many different contextual reasons. So we'll hear about different approaches to conducting COVID-19 surveillance in humanitarian settings. And we'll start with our first presentation from Dr. Wijekun, who from the World Health Organization. So I will pass over to her to launch her slides and take us through her presentation. Thank you very much.
Thank you, Oliver, for the introduction. Good morning and good afternoon to everyone. I hope you can hear me okay. If you can just let me know if you can hear me okay.
Yes, great, thank you.
Okay, so thank you for joining COVID-19 Surveillance in Humanitarian Settings webinar. Before we dive into the surveillance proper, let's have a look at the global and the settings that we're talking about. So this is a map of cases, COVID-19 cases around the world in the last 24 hours. 24 hours finishing on June 2nd. As you can see, most countries around the world are still reporting cases. It's scattered around the world. There's no specific location as such. Of course, there are places where there are higher caseloads than others. And the situation in terms of deaths per in the last 24 hours ending in June 2nd, that you can see. Again, many countries are still reporting cases. Some locations have reported cases in high numbers in particular countries. Now, what are the settings that we are talking about? So this is according to the Global Humanitarian Response Plans for COVID-19 by OCHA and its May update. We are talking about 63 countries, many of them having humanitarian response plans. Another set is having regional refugee response plans, refugee and migrant response plans, and 11 of other countries having existing vulnerabilities, though they do not have a humanitarian response plan in place. So you can see most of the...
Sorry to interrupt. Are you able to speak a little bit louder? Some participants are having difficulty hearing you. Thank you very much.
Okay, I think I will keep my mic closer to my mouth. Is this better? Better than...
Yes, much better. Thank you very much.
Okay, thanks. I hope you did not miss what I said due to the faintness of the voice. So just to remind, out of these 63 countries where there are IDPs, refugees, and migrants, most countries are concentrated in Afro region and Americas region and in the Eastern Mediterranean region. Now, there are a number of surveillance guidance WHO has developed since the beginning of the pandemic. These are basically for member states, for national and because of the specific reasons, which I will go into details in the next slide. We have also contributed together with a number of UN and other agencies, as mentioned in the slides, to include surveillance in ISC guidance. There was one in May, which was published more on readiness and response, scaling up of response in COVID-19 in camp and camp-like settings. And the most recent one being in May, not only humanitarian settings, also share some of the living conditions and challenges we face. So I believe most of you who are listening and joining today have used these and familiar with these guidance. And if you are a responder, already using them in the emergency settings. So if I elaborate a little bit about the challenges that, of course, most of the recommended, WHO recommended containment measures, starting from physical distancing, frequent hand hygiene, travel restrictions, etc., are not fully applicable to humanitarian settings. They may have some applicability, but in some settings where overcrowding is a common factor, physical distancing cannot be achieved to contain the outbreak. And then we also, we experience severe resource limitations when it comes to case detection, laboratory testing, case investigation, contact tracing, not having enough teams, not having enough resources, etc. So the idea of the surveillance guidance was not to provide a different set of guidance, but to provide more practical adaptation in a setting where there are resource adjustments. Now, strategy of prioritization under each transmission scenario is the key activity here. Now, I'm sure that you are very familiar with the 4 transmission scenarios WHO has published in previous documents, which should be aiding your preparedness, readiness, and response. Now, most countries in the world are not in the no-case scenario, but some humanitarian settings are still in no-case scenario, which will go into detail. Some may have sporadic cases, some may have clusters, some may be going into community transmission.
Look, the volume has reduced a bit, if you wouldn't mind. Thank you very much.
Okay, Hello? I'm sorry about that. I hope this is better. Yes, okay. Just to highlight the fact that we also did Global Health Cluster, wanted to capture the preparedness and the response in place for 27 country health clusters. We asked 3 questions, as you can see. The responses were rather good for these settings, and I hope the other settings, the refugee and migrant settings, also have some form of a early warning system, some form of a surveillance system to detect COVID-19, have plans or have had trained contact tracing teams and isolation capacity in place. I will rapidly go to the other sections because we have a little bit to cover. Now, we will go through case detections, laboratory testing, and contact tracing in a little bit detail. Now, if you are in the no case scenario, that is the best scenario to be in. You can be there in a comfortable manner if you know your system is capable of detecting cases. Now, COVID-19 being a new priority disease, you have to reorient your available early warning or surveillance system, introducing case definitions, introducing them to the clinicians, community health workers, and community health volunteers, also making sure that there are mechanisms for immediate reporting. In the guidance, as a part of the surveillance strategy and response, we also asked each humanitarian setting to conduct a site-specific risk assessment, which will usually enable you to identify the exposure risk factors, contextual ones, that will aid you to train and decide the number of tracing, active case findings, etc. So while we are in the case detection, one of the most important thing is the case definition. I'm not going to go into details about it. WHO also has, we have had several revisions of the case definition since the beginning of the outbreak. I think we are in the 5th one. This is what you can see in the screen is the current case definition. And we also have had revision to the probable case definition. So in a setting like humanitarian setting where there is limited expected case based on the strong suspicion of the COVID-19 will become a probable case in the absence of a testing capacity. Now in national reporting, you may have more confirmed cases than probable cases, but if you're reporting from a humanitarian setting where there is no testing capacity, you may have more probable cases because you simply cannot test the person with a strong suspicion to be having a COVID-19. We also ask countries to adapt and context to adapt the case definition depending on their setting. And we know there are a whole lot of humanitarian settings and countries where they have adapted the case definition.
It's just a 4 minutes notice, Niluka. Thank you.
Okay, just one thought about the sensitivity and specificity. I'm not going to go into detail about it. Most humanitarian settings, we have a sensitive case definition to identify cases. However, at the viral diseases and respiratory symptoms, which also share some of the non-specific signs and symptoms. So if you have a low predictive value, positive predictive value, also consider that you may be doing inappropriate contact tracing, which will be quite resource heavy and creating unnecessary public concern as well. So there's a fine balance between sensitivity and specificity when you want to detect, when you want to have a better case definition in settings where there's no testing. So if you have established outbreak with the PCR testing, the ideal situation is that you line list, investigate, line list all probable and confirmed cases. In these situations, suspected cases will become probable cases. When you come to community transmission, your resources may be quite overwhelmed. You might not be able to investigate, verify, report all the cases. In such situations that you might at least line list and report cases with severe signs and symptoms, those who are presented to the health facility. A few things to note, I'm not going to go into details. There's this risk of not detecting all cases in the community. A larger majority of them will have mild or moderate symptoms. They might not seek health care. So you have to have other public health measures to make sure the cases which are not detected by the surveillance system has no chance of spreading it to large groups of population. And one other thing, the shift of transmission scenarios can be very rapid. You may not have resting period in between them. By the time you detect the first case, sometimes it may be a case of a large cluster as well, or sometimes in community transmission. Now, testing, as I said, needs to be well aligned with the subnational and national level, because in most humanitarian settings, you might not have on-site testing capacity. The ideal situation is to test all suspected cases. If you cannot do that, you should at least try to test cases with severe clinical presentation. And when you have sporadic or clusters, when you have symptomatic contacts, consider testing symptomatic healthcare contacts, symptomatic vulnerable close contacts, or contacts with severe clinical presentation, because that will not only aid surveillance, but also clinical care, referral, and treatment, isolation, etc. So I'm going to go past this and to contact tracing. Now, contact tracing, you may have large number of contacts per person given the overcrowding situation, and that translates to large number of contact tracing teams. So we need to prioritize who should be tested in a situation of the transmission. If there are no cases, of course, you would not have contacts, but you still may have people in the quarantine, those who have come from a place of active community transmission. During sporadic and cluster situations, listing contacts, at least, if you cannot list all contacts, household or healthcare contacts, so that you can quarantine and make sure that they are.
Look, it's a one minute mark. Thank you.
Okay. So at the community transmission level, you may be quite overwhelmed to do community transmission, but it is not something to be abandoned. If you can still continue, you should still focus on the household contacts and healthcare contacts. I think I'm at the last slide. For any surveillance mechanism in this kind of a critical outbreak where contact tracing, quarantine, isolation is needed, surveillance depends on community awareness and participation. So it is not an extra addition, it is the basis that we have to improve our surveillance. So I believe that community participation and awareness, extra effort and strengthening during the, to improve surveillance. So I think that's all. Thank you very much.
Thank you very much, Naluka, for walking us through that presentation. Then we'll go straight through to Dr. Hayek and her presentation. And for participants, they can ask questions in the chat function as we go along. So over to you, Dr. Hayek. Thank you very much.
Thank you, Dr. Morgan. I will talk about the surveillance activities by UNHCR in Jordan. First of all, there have been 755 confirmed COVID-19 cases in Jordan up to this date, but no cases were reported in refugee camps so far. The government implemented strict measures from a very early stage, banning international travel and imposing lockdown. And the lockdown included the two main refugee camps in Jordan, Zaatari camp, which has a population of around 80,000, and Azraq camp, which has a population of around 40,000. Both camps have been closed since the 18th of March, and stringent measures on movements in and out are still in place. Before talking about the surveillance activities in the camps, it is important to mention that most refugees in Jordan reside in the urban setting, and they access the national health services as well as health services by private providers. And in the urban setting, they're integrated into the national surveillance system. We're not creating a parallel surveillance system in the urban. As for the camps, there is an existing and functional health information system managed by UNHCR that collects facility-based data on morbidity, mortality, and other health services. We've enhanced the existing system to make it more sensitive to COVID-19. First, we've established a clear mechanism for immediate reporting of suspected cases. There are focal points assigned at each health facility in the camp that reports immediately to Ministry of Health as well as UNHCR whenever there is a suspected case. The system also captures patients that are referred to out-of-camp hospitals for secondary and tertiary healthcare and become suspected at the referral facility. At this point, we're line listing suspected and confirmed cases, but as mentioned earlier, we do not have confirmed cases in the camps so far. We're using the WHO line listing format in conjunction with Ministry of Health and WHO at country level. Second, we are monitoring the trends of upper respiratory tract infections, influenza-like illnesses, and lower respiratory tract infections on weekly basis. We have an accurate population denominator for each camp, and we're calculating incidence rates and alert thresholds on weekly basis. However, we've been observing a decrease in the health facility utilization rate due to multiple factors, and this makes it challenging sometimes to interpret the alerts. We're also monitoring all-cause mortality and the number of mortalities per week from each camp. We've also added COVID-19 to the list of notifiable diseases to HIS. In this way, there is zero reporting on COVID-19 and not just reporting when there are suspected or confirmed cases. The case definition we're using in Jordan is the Ministry of Health case definition, which has 4 categories: any patient with respiratory symptoms and history of travel, any patient with respiratory symptoms and contact with a confirmed case, any patient with severe acute respiratory infection in any hospital in Jordan with unknown cause, or any medical staff with respiratory infection. It is worth...
sorry, Hiba, just a two minutes mark. Thank you so much.
Okay. It is worth mentioning that the National Epidemiological Committee in Jordan very recently recommended changing and expanding the case definition so it's more sensitive. However, there isn't any official communication from Ministry of Health on this regard yet. And based on the current case definition, we've had 14 suspected cases from Zatari camp and 4 suspected cases from Azraq camp, and they were all tested, and the test results were negative. PCR test results were negative for all. And regarding testing, the government has conducted over 190,000 tests all over the country. This included random sampling in both camps. In Zatari, there were 2 rounds. The first round included 150 samples using the rapid antibody test, and the second round was for around 120 samples using PCR, and there were no positive PCR results. In Azraq, there were also 2 rounds, and both were using PCR for around 400 samples. Perhaps one of the main challenges we have is that testing is centralized, and this causes delays in obtaining the results, but there are efforts from the government to decentralize testing. In addition to the surveillance activities just mentioned, I would like to mention that there is an existing structure for rapid response teams as part of response outbreak and response plans in the camps, and they've been reactivated for COVID-19, and they are mainly from Ministry of Health at district level. Contact tracing measures have been defined with Ministry of Health at camp level. Ministry of Health will do contact tracing for confirmed cases as per the national protocols. And for the suspected cases, we've had household contacts were given advice to restrict their movement, and they were given advice on when to seek healthcare. And lastly, there are community health volunteers in both camps, and they are part of the community-based surveillance activities. In Zaatari, we have 76 CHVs, and in Asraq, there are 37. That's a ratio of 1 CHV per 1,000 population. And aside from their activities in health education and awareness raising, they've been trained on the COVID-19 case definition. And, but given that the current case definition is specific, their role and that patients need to be identified at the health facility, the role of community health volunteers to detect cases at community level is limited for the time being. But this could change if the case definition becomes more sensitive. So we're continuously revising our strategies in the camps, and we are aware that some surveillance activities might need to be adapted as the situation changes. Thank you.
Great, thank you so much, Heba. Thanks, fascinating and a huge amount of work that's ongoing in Jordan. We'll turn over to Naomi to give her intervention, and just to remind colleagues that you can ask questions in the chat function, and we'll address those during the Q&A. So over to you, Naomi. Thank you.
Okay, thank you, and good afternoon to everyone. So Kenya currently has also joined the statistics of the COVID-19 in the world. The current confirmed cases being 2,093, total recoveries being 499, and the number of deaths confirmed as 71. So generally in Kenya, we are adopting 3 forms of community-based surveillance, types of surveillance. That is community-based surveillance, event-based surveillance, which is a government system, and indicator-based surveillance. So I'll major more on the community-based surveillance, which is an active process of community participation in detecting, reporting, responding to, and monitoring any new events in the community. And the model adopts both passive and active surveillance. So when we talk of passive community-based surveillance, both in the humanitarian settings and across the country, we mean that the volunteers are still carrying their routine health awareness and diseases, prevention activities to communities. They may take notice or be informed by the community about diseases potential for epidemic, and they can report this to the potential alerts to their supervisors. When we talk of supervisors in our country settings, we are talking of Ministry of Health care workers or animal health veterinary officers, because epidemics can take the form of animal health or animal diseases. Then we have active surveillance under the community-based surveillance, which is the active search of cases like what we are doing now in regard to the COVID-19. We have the household visits and networking, the communities tracking. I'll talk later about how we are scaling down the household visits. And we have the daily CBS reports, that is community-based reports, and disease control actions through mass actions, which takes a different form given the current status of COVID-19. Surveillance in humanitarian setting has become a challenge, as some of my colleagues have said, but Kenya Red Cross has been trying to do various interventions, given that we really have to take care of our communities. The organization is lucky because it has a pool of over 85,000 volunteers who are embedded on the Ministry of Health structure, namely community health strategy. And all these volunteers are trained on community-based basic first aid. Since the rollout of epidemic control for volunteers in the year 2019, which is a pilot study in Kenya within a few countries, majority of the volunteers are now either trained or sensitized on epidemics, and more so the COVID-19 basics. Because when a newly emerging infectious disease is first identified, specifying appropriate case definitions can help to identify individuals who are infected in an efficient manner, thus reducing disease spread. Volunteers are taken through simple case definitions of the epidemic diseases using simple technology, that is short SMS, and they send alerts for any observed unusual events in the community. The recipient of the SMS, as I said earlier, is a nurse or a clinical officer or a public health officer or a veterinary officer who is able to decode the SMS and follow up with the volunteer. Each volunteer has a unique code and a village ID explaining when the alert is sent, the public health officer will decode and know this alert has come from a particular volunteer from a village or from the whichever camp, and the village number will also guide the officer or the supervisor to be able to follow up with the case. When we talk of community case definition, which we use, or community case definition, it is a simplified version of the standard case definitions, which is adapted to suit the needs and the resources of primary healthcare professionals and more so community health volunteers. Examples of such case definitions that we are using to ensure that the right alerts are sent is, for example, if a volunteer identifies a person from the camp or from the village with fever and rash, that is fever, he or she will set the code to the supervisor, and the supervisor will be able to decode and maybe lead to the system-generated diagnosis for measles. Featuring more on COVID-19, the case definition which we have shared with the community is fever and difficulty in breathing. So any volunteer coming across a patient or a suspected case of a person who has cough or difficulty in breathing will set the alert to the supervisor, and the necessary measures will be taken. Other examples, I talked of animal alerts because we have not forgotten that besides COVID-19, there are other epidemics which have been there. We have livestock diseases, which the volunteer can identify through simple case definitions. For example, livestock abortions. It can be referring to Rift Valley fever, or even deaths of unusual breeding can be a diagnosis for anthrax. But now the community health volunteer is not the medical person, so they'll send the alert to the appropriate people, which will help in generating the diagnosis. Now, talking of how we are taking care of the continuity of surveillance, the organization is lucky because it had
I think we might have lost Naomi. Naomi, can you hear us? I'm afraid I think we might have lost the connection with Naomi. I suggest we actually turn over to the question and answer session and see if Naomi is able to rejoin us. Yes, it looks like her connection has a problem. So we can turn over to do some question and answers, and then we can invite Naomi at the end to conclude if she's able to reconnect. And maybe Tony, you are able to reach out to her while we're online doing the Q&A and see if you can help her reconnect. So thanks very much to the presenters and discussants. And I'll open the floor to questions. Maybe I will, invite, thanks Heba for coming back on, and invite Niluka to come back on screen. And I will, why don't I start with the last, there's a question here, I think asked about, I'm just going through the chat function, an interesting question here from Oracle Cruz, who actually works with the WHO Emerald office. And she asks, is there a common platform where all agencies conducting surveillance in humanitarian settings can enter the data and enter and share the data? So maybe I'll ask that question to Heber, and Niluka might want to follow up. Oh, thanks.
Thanks. For UNHCR, there is a platform for all UNHCR operations to enter data on COVID-19. There's a system, integrated refugee health information system. And I see Naomi is back, but I'll continue answering the question first. And even if the country doesn't use this platform yet for normal health information system activities, it could be used for COVID-19. As for a platform for all humanitarian actors, this, I think Dr. Nailuka could give a better answer on this.
Thanks. Over to you, Nailuka.
Thanks, Heba, and thanks, Ora and colleagues, for the question. It's a very, very relevant question, having a common platform between refugee settings as well as refugee and migrant settings and IDP settings. And this is something that we are working on. We are having discussions with UNHCR, and WHO recently at the headquarters level also had a memorandum of understanding under COVID-19, sharing data and collaboration, and we have excellent partnership with them. So in the coming days and weeks, we will be looking into having a common platform or easy collaborative data sharing between refugees with IOM. Cases are already burdened with different reporting mechanisms. We are trying to look into a common, easy way of sharing data on a regular basis, so that the colleagues in the refugee and IDP settings and migrant settings are not overwhelmed by that. So this is work in progress, very much in our radar, and we are working towards that. Over to you.
Great, thank you very much, Nailuka. And welcome back, Naomi. I'm sorry that we lost you. I'm wondering if you could just make some concluding comments and then to try and wrap up your intervention, and then we will return to the question and answer session. So back to you, Naomi. Thank you.
Okay, thank you very much. Sorry, I lost the network. So I was explaining how we are doing the community-based surveillance and the active case finding as part of the support to the humanitarian COVID-19 responses. Active case finding is also part of the surveillance, but requires community cooperation given the challenge of stigma associated with COVID-19. Then the community engagement and ensuring that operations are accountable to affected people has really helped us, and is a priority and an essential part of the humanitarian response. We have also tried to come up with other complementary ways to help us do our surveillance effectively without causing any harm or stigmas or risking the lives of the volunteers. So what we did was first do the community needs assessment, and then we conducted the humanitarian response, so that you first respond to the need before going to look for people. Otherwise, they will not cooperate. The cross had to respond to this first for ease of access, for surveillance, among other interventions. Also, through the government, we have been involving other key community stakeholders like the herbalists and the chiefs in the villages. When I talk of the herbalist is because when a person is sick, and because of the issue of the stigmatization and fear of the quarantine, they may end up going to the herbalist. So the government has really brought these people together as the key persons from the communities, such that if a person decides to go and see a herbalist and they display the symptoms of COVID-19, the person can send reports to the public health officers. So that is how we are doing surveillance in the simplest way possible at the community level. So what I want to conclude by saying that community-based surveillance is not a parallel system to the traditional event-based or indicator-based surveillance, but it's only a voice from the community, and it's complementing to the other conventional methods that the government has laid down. So we are sure that the community has a voice in taking care of epidemics, especially the COVID-19.
That's great. Thank you so much, Naomi. And I'm glad that we were able to reestablish the connection and have you back. So thank you. If you can stay on, actually, and I'll ask the other speakers to come back on and then we will have some question and answers. So participants can ask additional questions in the chat function, or you can come online and ask your question in person as well. And you can, I'd suggest use the raise hand function if you'd like to do that. So I'll just go through and select another question. This question from Ali Ardalan said, are there any regulations for cross-border collaborations to improve surveillance in humanitarian contexts? Maybe I'll start with that question to Niluka and then open up to Heber and Naomi.
Okay. I got the question well. In Kenya, we have a scenario of cross-border. For example, across the Ugandan, Kenya border, Tanzania, Kenya border, Ethiopia, Somali, because of the Dadaab and Karoye Bay camps. So it's a bit hard, but what we are trying to do is we really try to work with the local government system and enhance the community networking, because with or without the government regulations, we'll have people sneaking and use other routes, and that has really caused a lot of is exposing us to the danger. But what I can say has really worked well is the border in the East African countries, that's Uganda and Tanzania. The two governments agreed to have common screening so that when people decide, because the routine activities and the neighboring communities will always cross, what the best thing is to work as a team and enhance the screening processes together. Yeah.
Thanks. Maybe I'll pass that question to Niluka. Hi, Niluka, can you hear us?
Yes, cross-border. I hope you. Hello.
Yes.
Yes. So it's again it's a work in progress, and this is something that we also need to discuss with regions as well as different humanitarian settings where there are cross-border surveillance will become a related topic. And so this is one of the activities we have towards places where they run crossings, etc., and improve surveillance in these settings. So I believe that I still don't have, we still don't for it, but this is something that we are working on. Over to you.
Thanks very much, Niluka. Heber, did you have any thoughts on that question about cross-border surveillance?
It doesn't really apply to the Jordan context for one simple reason. There are no refugee movements across the border in Jordan, at least for the time being, but if there were, yeah, there would be screening, but just downscaling this to the camps, there are screening at the refugee camp entry, whether it's for returnees, refugees coming back from the urban setting to the camps, or for the health workers or essential staff that need to be present at the level of the camp. So the same principle is being applied at the camp level, but we cannot call it cross-border surveillance activities.
Great, thank you very much. We have a question here from Eva, and it's directed to Niluka, but I will also invite both Heber and Naomi who might want to answer. That's how can we have systems to better understand the proportion of probable cases that are true cases in humanitarian settings where there's limited testing? How do you see the role of targeted serology studies? So I'll turn that to Niluka and then ask if either Heber and Naomi would like to comment on that.
So yes, and I saw that there was another question about case definition, also asking about the pediatric case definition. So WHO is in the process of a revision of yet another case definition. So we're working on this and especially improving the probable case definition. So as I showed in the presentation, our current probable case definition can be improved further, adding more specific clinical signs and symptoms, especially considering places where testing capacity is unlikely to improve. Of course, if the zero prevalence studies can be conducted, that will be helpful, but this situation might not be generalized for all settings. Most settings are struggling even to detect suspected cases and manage among measles, malaria, and especially we are going into season of various diseases. So we are in the process of this improving case definitions, making it more specific so that we have a better predictive value, still relying on specific signs and symptoms, because some combinations have proven to be high specific and some countries have used these things, or perhaps adding simple tests without giving much information, whether the possibility of adding a chest x-ray or etc., where PCR testing is not possible. So this is some discussions, reviews we are going through. So hopefully we will be able to soon have a revision to the case definition so that we have a much specific probable case definition. Over to you.
Thanks, Niluka. Actually, I might turn to Naomi and just ask that question, but in a slightly different context for community-based surveillance. How in Kenya are you managing to respond to the signals generated from community-based surveillance about suspected cases? Are you able to refer samples to laboratory testing, or what happens? I know you did mention rapid response teams, but I think Heba mentioned that. But Naomi, how do you manage to address signals coming from your event-based surveillance, community-based surveillance?
Okay, thank you. As I explained earlier, the humanitarian organizations, more so Kenya Red Cross, complements government efforts. Ours is majorly community-based mobilization. So the issue of testing and screening is purely the government role. But what I can say, I know even when we do the community mobilization in various regions and towns, each region has a referral center, and with the current crisis, we were able to, there is activation of the regional testing centers through the support of the CDC. So ours is purely community mobilization, but the government has put all the efforts to ensure that the communities can access the right testing services through the linkage and referral system, which is quite functional.
Great. Thanks, Naomi, for that. Heba, did you have any reflections? Shall I move to the next question?
No, I do not have any comment for now. Thanks.
Thanks. So we have a couple of additional questions. There are around serology and behavioral surveys similar to those done for HIV. A question asked by Nada. Maybe we could have your views on whether indeed those types of surveys would be useful and how they might be conducted. So maybe Heba, you might want to have the first go at this question. So how are serologic surveys and behavioral surveys, such as the ones done for HIV, planned for populations living in humanitarian settings?
Well, that's a very interesting question, but to be able to give an accurate answer, I prefer to double check and get back in writing on this question, please.
Okay, thanks, Heba. Maybe for Niluka, are you aware of plans for serology studies in humanitarian settings?
Not that we are supporting directly, but I can check on this and let you know. Yes.
Thanks. And maybe to Naomi about the either the serology or the behavioral components of surveillance.
Okay. If I still focus my answer on the community because we are more on the community level.
Yes.
What we are encouraging the community is the issue of behavior change. The volunteers have been taken through the 5 steps of the behavior change, that the community have the knowledge, they have the willingness to take the information positively and demystify their beliefs depending on the correct knowledge, and even have taken action to go and access the testing. So the issue of the results, I may not so much discuss about here because ours is purely community social mobilization to access the surface. So the result testing is the discretion of the government. Yeah.
Yes. Thanks. I think from the serology side, I'm aware of a number of different sero surveys that are being planned, often in locations where they have existing infrastructure such as DSS sites. But I'm not aware of any specifically in humanitarian settings. Maybe it's useful to note that there are still quite a number of challenges with the serologic assays themselves and the performance of those assays, which is making the application of serologic surveys somewhat challenging at the moment. I expect that we'll have some not only better functioning assays, but also better understanding about how the existing assays function. That work is ongoing. So I think that we will see some results fairly soon. So let me turn to the question asked by Breda, which is, how is the surveillance inputting into national Ministry of Health HMIS, such as DHIS2, and supporting overall surveillance? I think it's probably for the country. So maybe, Heber, I think you mentioned this in your comments about the interaction between surveillance done for vulnerable populations and the national surveillance. Maybe you could give an idea about how that integration works.
Okay, so in refugee camps, the health information system is managed by UNHCR, but it's done under the umbrella of Ministry of Health. And there is coordination with all health actors in the camp. And the reports, the surveillance reports that we generate on weekly basis are shared in a timely manner with Ministry of Health. So there is data sharing with Ministry of Health, and they mainly rely on these reports for the camp population. For the urban setting, it's mainly managed by the government, the surveillance.
Thanks, Heber. And Niluka, to that same question, are you aware of toolkits or any type of support that partners can access in terms of setting up surveillance for COVID-19 in humanitarian settings if it's not already up and running?
Yes, there are a number of tools used for different purposes. Now, because we talked about DHIS2, DHIS2 also has a module specially created for COVID-19. And it also has different parts for point of entry screenings, for outbreak, contact tracing, and different modules for each under this package for COVID-19. We know a number of countries, especially in Afro region and other countries, where they have DHIS2 as the platform for normal HIS for the national service, is using this. I think this was started as the first COVID implementation in Sri Lanka and successfully implemented. That is one. So some settings are using this. And for the outbreak purpose, sometimes use I hope you can hear me. So in settings where there is good.
I think you might, if you turn off your camera, Niluka, that might help with. stabilize.
Tracing purposes. And there are details. They use different types of warning, early warning systems, including It Was in a Box, which is supported by WHO. So they also use it for outbreak response for COVID. And there are a number of tools people use, and there are other often open source applications also used for certain settings. Over to you.
Great, thank you very much. I think we're running to the end of the session. There were a couple of other additional comments in the chat around IDPs in Sudan and Somalia. Paul mentioned, yes, Djibouti, Rohingya camps, and there were a few other comments in the chat function. So if I see there's a request for the link to DHIS2, I'm sure we can ask Tony to send that out. I think we're coming to the end of our time. I'd like to end by thanking our speakers, Niluka, Heba, and Naomi. Thank you so much for joining us and sharing your experiences about conducting surveillance for COVID-19 in humanitarian settings. I know that I'm sure we'll be speaking again soon, as this will be a long-running challenge, as mentioned by one of our colleagues in the chat function. This will be an activity that we'll have to be working hard at for quite a time into the future. So I will turn over to Paul, if Paul is online, to kind of do the final wrap up and to introduce the topic for the next webinar. And from me, I would like to say thank you very much. It's been a pleasure to be able to chair and host this session. And please reach out to us if there's some information that we can help with. So over to you, Paul.
Great, thank you very much. Thank you, Oliver, for moderating, and thank you, Niluka, Naomi, and Heba. Very interesting, and as you said, this is going to be. There are a lot of big issues, and particularly because of lack of testing that makes it so complex. I just want to briefly announce the next 2 sessions. So we have extended for another 4 weeks, and next week we'll be looking at maternal child health issues in humanitarian settings amongst the COVID pandemic. And then following that, we're going to be looking at non-communicable diseases in humanitarian settings. We've been dealing a lot with COVID directly, and we're, as with everyone, very concerned about both in maternal child health and non-communicable diseases, how they affect COVID, but also the issues related to non-COVID related excess morbidity and mortality as we concentrate on COVID itself. So thank you, everyone, and thank you again, Oliver and colleagues. We really appreciate it because we know how crazy busy everyone is during this time. And have a good rest of the day to all of you. Goodbye.
Thank you. Bye-bye.
Bye-bye.
Thanks and bye.
Goodbye, thank you.